Good evening to each and every one of you who have logged in on this July 19th, our regular IFS Tamilnadu webinar, which we have every third Tuesday. It's a pleasure that for this meeting, we have all the doyens who have logged in to give us the nuances of ovarian stimulation, how to handle a high responder, how to handle a low responder, how to handle a poor responder, and a person with a premature ovarian failure. So I think we're going to learn so much from our seniors. So we have two small talks followed by a panel lined up. And without further delay, I would like to invite the chairperson of the first session, Dr. Sonia Malik, to lead the proceedings of the first session. It's a pleasure to introduce Madam, vibrant, and I must say, there's not a day I have seen her without a smile. And she relates a lot to the PCOS because she is the person who brought a lot of PCOS recommendations and guidelines. She's the director of Nova South End Fertility Center, past president of Indian Fertility Society, past president of Indian Menopause Society, chairperson in Infertility Committee of FOGSI. And she's been an editor and participated as a past editor and editorial board in many journals. I must say, she's received many awards to her credit. I can just say that all the three people who are there in the first session are past presidents, and they are young, frozen at 20 to 25 years of age. And the first of them who would start speaking now is Dr. Sonia Malik. I would request her to introduce Dr. Jain.
Thank you so much for that, Rajpriya. Thank you so much for the introduction. And thank you, first of all, for having all of us here and me, of course. It is indeed a great pleasure for me, and I wouldn't say an honor, I would only say pleasure, because it is a great pleasure to introduce two of my very, very good friends whom we have traveled together in this path of IFS right from the beginning, and therefore we have grown together in this field of infertility and fertility. So hence, I think probably this is the first time that someone has brought all three of us together on one platform. I'm really, really happy for that. And the first one out of us is Dr. Kuldeep Jain. I'm sure the audience is very familiar with this name and this gentleman. He has been around in the field of infertility for the last 25 years or more. He's presently the director of KJ and Laparoscopy Center at Delhi, and he's a laparoscopic surgeon par excellence in addition to being a clinical embryologist. So basically, he's all in one. It's a package of everything in ART together, and multifactorial, multi kind of imaging. So that is what he is, and I think nobody better than him could have been chosen today to talk about this topic of hyper-responders. We all know that hyper-responders are a great challenge to us when we are trying to stimulate them. In fact, when we get a patient who is going to behave like a hyper-responder, we start treating them right from the beginning. We start looking at it as a challenge even before we start stimulating. And when we are stimulating, Dr. Kuldeep is going to tell you what are the challenges ahead and how he tackles them. So over to Dr. Kuldeep for his wonderful deliberation on ovarian hyperresponders in COS. Unmute yourself, Dr. Kuldeep. We can't hear you.
Thank you. Can you hear me now?
Yes.
Thank you, Dr. Sonia, for the introduction, which is actually gives lot of encouragement, rather what I will say. And as she has said that this is I think a very rare thing that we all three are there. So thank you, Rajpriya, for this opportunity. I think IFS Telangana chapter is doing a very great job. So I must congratulate to whole team and especially Dr. Rajpriya for organizing this and having all of us here. My topic today is mild stimulation for high responders. Why I accepted this, because first lecture on mild stimulation I took almost 10 years back, and after that not many conferences have included this chapter especially. And over the period, we know that the stimulation strategies, they have really changed for a better outcome. So let us see what all has changed in last 11 years. Terminology has changed over the period. Previously, it was unstimulated spontaneous cycle. Now it is natural cycle IVF, semi-natural, controlled natural cycle. Again, now it is called. So it is coined the various terminology already are in place. So there is not much confusion when we compare two studies. So modified natural cycle IVF and what is mild IVF, which I am going to talk to. I will not be speaking to all these because the time constraint is there. But certainly mild IVF is now what all was there: soft IVF light, minimal stimulation, friendly IVF. So this is all mild IVF, and then we are having conventional IVF. So actually mild stimulation, we are having a international society on minimal stimulation, and they have taken this mild stimulation very aggressively. But in clinical practice, there is still a lot of dilemma. Most of us are not practicing it universally. So we will see what are the limitations and why we are not practicing mild stimulation in all cases. Of course, there is a visible shift in the focus. Previously, maximizing instant success at all costs. That was the IVF 15 years back. Like we wanted to have at all, whether the patient is going for ovarian hyperstimulation or for any complication, we have to have a pregnancy. Now we have moved actually to safer and more friendly protocols, balancing risk and benefits. Of course, we want benefit, but the risk has to be avoided. So that's why the concept of mild ovarian stimulation comes into picture. It is based on the principle of optimal utilization of competent oocytes and embryo, and of course, improving the endometrial receptivity. So what is mild stimulation? If we see, basically mild stimulation are all stimulation protocol where the gonadotropins is administered in low doses or for a shorter duration. So either the duration is cut or the starting dose is very, very low. And then we are having antagonist to be introduced to minimize the risk of ovarian hyperstimulation. Or when oral compound like antiestrogens or aromatase inhibitor are used in combination with gonadotropin. So both of them, they qualify for mild stimulation. Why mild stimulation is not very popular? There are multiple factors. Like insecurity among clinicians is one of the acceptance is not grown over the period, and there is always in the mind that if you are having fewer oocytes, you may not get a pregnancy. So that is the limitation factor. Less success rate. We will discuss how we have evolved. And increased risk of cycle cancellation. Again, this is very, very important. Cycle cancellation is slightly higher, reported in various literature. But over the period, convincing data emerging in favor of mild stimulation. These are some of the weaknesses which are coming from various studies. Low success rate. Again, optimal number of oocytes are low. So that is the limitation. Now, various clinical compulsions are all there. Everyone wants to get higher pregnancy rate. And there is a philosophy that more egg will give higher pregnancy rate. Of quoted that if you are having 14, 15 eggs, you will have better pregnancy rate. Then opportunity for cryopreservation. We are always looking that in one cycle, we should have at least vitrification for next 1 or 2 cycles. So these are some of the clinical compulsions which we have to take into effect. These are the limitations basically of mild stimulation. High standard in laboratory. If you are not having a good laboratory, you cannot practice mild stimulation. So that is very, very important. Fewer embryos are there, so overall efficiency becomes less. Though cumulative pregnancy rate, if you compare, there is not much difference. And of course, now we are generating a lot of data, but initially the data was not available in favor of stimulation. And these are some of the clinical dilemmas. Can mild stimulation be practiced in all group of patients? I will be touching only higher responders, but it is suggested by some of the people that it can be practiced in all three varieties. Now, the concept of mild stimulation IVF is as effective as conventional IVF. Here, what we are doing, only healthier follicle are recruited, so we are having more competent eggs. The physiological hormonal milieu is near to natural cycle, so chances of implantation are slightly better than conventional IVF. And of course, the dosing of gonadotropin and cost comes down. These are some of the advantages and disadvantages: patient discomfort, fewer injections, lower cost, lower risk of OHSS, possible improvement in receptivity. And of course, the disadvantages are we have cycle cancellation is one of the major disadvantages, and lack of cryopreservation. So coming on to high responders, what are the problems if we are using conventional stimulation? Risk of high OHSS is very, very important problem in high responders. So if you are using conventional protocol, risk of OHSS is very high. E2 level are supraphysiological. So if you are going for a fast transfer, poor implantation is reported. And then there are multiple effects of high serum E2, which takes its own toll. So mild stimulation, is it better for high responders? What are the various studies? This is a landmark study in 2007, and they said that number of euploid embryos are almost same when you are comparing mild stimulation versus conventional stimulation. So even if you are increasing the number of oocyte in conventional protocol, you are not getting a higher number of euploid embryos. Again, this is a very recent study of 2014, large RCT. They said that there is no increment in the number of good quality blastocysts. When you compare mild stimulation and conventional, there is no increment in good quality blastocysts. And they have said that if you are having blastocyst oocyte ratio, then there is an inverse relationship with dose of stimulation. So if you are using high doses, the blastocyst oocyte ratio conversion will be low. So they concluded that mild stimulation may be better for high responder. Then there are other several studies. They are again focusing on high proportion of good quality embryos which we are getting in mild stimulation, and they have again suggested that it may be a better idea to have mild stimulation for high responders. Now, this is very recent RCT comparing the outcome, and again similar clinical pregnancy rate and increased OHSS in conventional stimulation. So now the data is available when we compare mild stimulation and conventional. Mild stimulation may be better for high responder cases because you are getting the same number of blastocysts. You may get cryopreservation embryos also, and at the same time you are reducing the ovarian hyperstimulation risk. This is again a recent Cochrane data. The incidence of OHSS was less when a stimulation dose of less than 150 was applied for hyperresponder, but the live birth rate was not different. So whether you are using a higher dose or lower dose, the live birth rate remains same, but the risk of OHSS can be decreased. These are some of the older studies which have again focused on the OHSS more than the clinical pregnancy rate. This is our pilot study which we conducted 8 years back in hyperresponders using mild stimulation protocol. We selected 41 cases, all were high risk for OHSS. We used letrozole combination with gonadotropin and antagonist, and on an average 4 to 8 eggs were recovered. no OHSS, no cancellation, and conception rate was as good as around 48-49%. So we can say that mild stimulation in hyperresponder does work and minus ovarian hyperstimulation. This is a different paper which is actually against mild stimulation. He has concluded that severe OHSS, oocyte amino quality, pregnancy, life, birth rate, cost, everything remains same. So there is not much benefit of mild stimulation when we compare with conventional, especially in hyperresponders. We don't agree with this study because the OHSS risk is always less with mild stimulation. You cannot just eliminate, but yes, you can reduce by using mild stimulation. Now, how many eggs are sufficient? Because that is the thing which is always in our mind. Again, conflicting data. One study, RCT says only 6 oocytes are adequate to give a live birth pregnancy rate equal to any other protocol, while other studies again focus on number 13 to 15. So if you are using mild stimulation, you may not get that number. These are various other advantages which comes with the mild approach. Cost, certainly it is reduced because you are using less number of gonadotropin ampule. So what are the opportunities mild stimulation is giving? Development of low cost regime, maybe oral compound has to be used more and more in conjunction with gonadotropin to get a better pregnancy rate. Mild stimulation in more advanced age again is suggested in poor responder. I am not going to talk on that. Lower dose of SCG can be used in conjunction in place of FSH, and of course improved safety and development of various protocol for non-fertility indications. These are some of the threats which all clinicians have to face. The clinical resistance is there, pressure on clinician to achieve high result in each cycle, cost consideration. So these are the things which we need to keep in mind. These are the proposed direction. We have to have mild stimulation, mild ovarian response, but reduce cancellation and over response. So this is important. Strict single embryo transfer policy, if you are having, certainly mild stimulation will be much better. We have to develop cheaper stimulation regime and effective in more advanced group, even in PCOS, which is advanced age, we can use mild stimulation. This is where the future of mild stimulation, the 20 RCTs were identified comparing mild stimulation versus conventional. More than half were large trials. This is a very important sign over the last 8 years. But the finally, there is no clear conclusion that all patients should go for mild stimulation. There is a trend towards better outcome in poor responders, but as far as the hyper responders are concerned, there is no data on live birth rate. Looking at the bigger picture, currently available evidence base does not support the concept more is better. This is the important thing when it comes to balancing cumulative live birth rate with safety, treatment burden, and cost of the patient, and of course the society. So concluding my talk, mild stimulation may represent an important step forward. It is more tolerable, problem-free, and cheaper. Effectiveness is actually the core of discussion, because this is where we have to generate more data to make it more acceptable. Well-designed comparative studies are needed, the need of however for different subsets. So mild stimulation gets its place in clinical practice. There is a growing evidence that in good prognosis patients as well as in poor responders, administration of lower than standard stimulation dose with or without oral agent does not compromise live birth rate. I think if this data is generated, we will have more and more acceptance of mild stimulation. Risk of cancellation to be weighed against risk of OHSS to choose between mild stimulation IVF and conventional IVF in high responders. Thank you very much for your patient hearing. I am open to any question. Thank you.
Thank you very much, Dr. Kuldeep. That was a wonderful summation of all that we should be doing now for making our patients more safe as far as COH is concerned. Dr. Rajpriya, are we to take the questions now or at the end of the second lecture?
So depending on whether sir has time, ma'am, if sir doesn't seem to have time, we can do the interaction now.
Okay.
Otherwise, we can have high and low responders together for discussion. Depends on sir.
So can I ask the questions then?
Yeah, ma'am. I think then we can let go of sir.
So Dr. Kuldeep, my question is, and I don't see anything in the chat box, that's why I'm asking. My question is that is there any data to tell us that the quality of the eggs also improves with mild stimulation? Because you see what happens is many times when we are doing the conventional IVF, many of these patients will end up with abnormal oocytes, We know this in PCOS. So suppose you are doing a mild stimulation and you end up with all abnormal oocytes, then what happens then? Because sometimes the patient comes with 17 oocytes and only one blastocyst forming or maybe one embryo forming. So what do we do in that case? Any studies on that?
No, actually that type of study is not available, but they have compared the mild stimulation with conventional stimulation, and they found that good blastocyst blastocysm rate was almost same in both the group. So even if you are having a high number of oocyte in conventional protocol, you may not get the good blastocysm rate because most of them they are not euploid. So that's why it goes in the favor of mild stimulation. Mild stimulation more than the conventional protocol.
So there is a
so
question.
that data is available. That data is available. There are three large studies which have focused on this aspect, and all have said that the number of euploid embryos and blastocysts was almost same in these large studies.
So there's one question in the chat box. What is the dose and what choice you make in your practice for mild stimulation?
Sorry, can you repeat it?
So in mild stimulation, what is the dose protocol you are following in your setup? There's a question.
I think you have to take into consideration the AMH values as well as the day 2 scan to decide the dosing. Like in my practice, usually when I am combining, if the patient is having very high AFC and high AMH, then we are combining letrozole with gonadotropin 75. Previous response is also to be taken into consideration because most of these patients, they have already taken letrozole for IUI. So if with letrozole IUI in IUI cycle, the patient is developing 2-3 cycles, then 75 dose will be advised. And if there was a poor response, monofollicular growth with 5 milligram of letrozole, then I am starting with 150.
So you prefer using pure FSH, sir, or rec FSH?
Yeah, usually. If the patient is young, again the age factor has to be taken into account. In all younger patients, we are using recombinant FSH. But in older patients, I do prefer HM.
Thank you, sir. Any more questions, ma'am?
I don't think there are any more questions. Thank you very much, Dr. Kuldeep. Thank you so much.
Thank you, Dr. Sonia, and everyone. It was really wonderful interacting. I am here till my patient is ready.
Yes. Thank you so much, sir. Sahidi, can you play Dr. Sudha CV, ma'am? She'll be the next speaker. Madam, can you introduce Sudha, ma'am?
Yes, please. So now we move on to yet another great IFS leader, Dr. Sudha Prasad. She has been the immediate past president of IFS. We all know her very well, a very dear friend, a great human being. She is a very, very, very well-known teacher. has been the director of the IVF Center at Maulana Azad and has been in the teaching faculty for a very long time. More than that, what goes to her credit is that she has established the first IVF center in the public domain. And, she had to face lots of struggles. We all know that because we've struggled together during this period, that she went through a lot to establish that center in Mamsi. And now she has her own practice. Her own center is called Maitri, and she runs a very successful IVF center in Delhi. So, Dr. Sudha, with so many awards and accolades to you, congratulations, and please come on. Please come on, Dr. Sudha. Thank you. She'll be talking about the other aspect of COH, that is poor responders.
Thank you so much. What has happened? Can you see my screen? It might
able to see, ma'am, but the whole thing is there. Maybe the
slideshow. You have to make it slideshow.
But it is very small. I don't know.
Yes. Change it to slideshow. Dr. Sudha, the slide has become very small. Can you see that thing on the side? It has gone to the lowest point.
No, it is slideshow.
Yeah, now it is. Yeah.
No, slideshow thing has gone somewhere. I don't know.
The icon is not there.
Yeah.
At the lower end of the slide, at the lower end of your window.
Now it's coming. Now it's coming.
Yeah. Okay.
Now you have to go to the slideshow, ma'am.
Yeah,
yes.
The icon is seen now.
Let me.
Please click on slideshow, ma'am.
Yeah, I'm trying to click.
There, right down at the bottom. Yeah.
It's not still slideshow.
Still, it is not.
Oh, we are able to see it, but here.
Dr. Sudha, at the lower end of your window, there is slideshow also. One on top and one at the bottom. At the bottom
one, click on from beginning.
Is not visible actually.
For her, I think, yeah.
Acha, okay.
Sahidi, so how should she go about it now?
Let me put again for the once more. No, this one I have clicked, but it is not somehow.
After clicking that, click on from beginning.
Click on from beginning. Where is that scene, ma? Oh, madam. Yeah.
Something
is next, Doctor. Next slideshow after animation. This one, yes. Yes, this is slideshow.
It has gone too small.
He's saying from beginning you play, ma'am. At the left end,
at the left there is from beginning, ma'am. You can click on that.
There's some problem.
Oh, ma'am.
Ma'am, or else share it again, ma'am. It will.
I think so. That's what I want. That's what I want. Just give me 1 minute.
Sure, ma'am.
I think there is some problem in this feasibility.
Ma'am, now click on slideshow once. Before minus symbol, there is one icon. You can click on that also at the bottom.
Bottom one is there. It's not visible. I don't know why.
Okay, ma'am. Here
I have rotated it. I hope.
No
should-
problem, ma'am. You can click
Thank
on.
you.
So
Yeah, now it's fine, ma'am.
Thanks. It has visible now. So sorry for the delay.
That's the thrill in the webinar, ma'am.
I know. So thank you, Rajapriya. And I really congratulate from my core of the heart the way the energetic girl is doing so good. And we really, IFS really need the energetic people. And we are doing, IFS is really flourishing and doing so well with you people. Thank you so much for taking the flag of IFS at the height. So here we are going to talk about the planning stimulation for POR, poor responders patients. Dr. Kuldeep has taken so well with the mild stimulation, with the high responder, and now this poor responder comes. So these days we are seeing so many patients of poor responder, whether they are young or older, it comes to same. And it is not at all uncommon, but it is definitely a big challenge for the fertility specialists. The oocyte quality is not related with the number of oocyte, but definitely if the patient is young, even though the response is not very good, but few embryos can be euploid and it can make the patient pregnant. So this is very much important that you are working with whom, you are managing with which kind of patient. This is very much important. And the poor response of the incidence rate which we have seen, it is nearly 9 to 24% of the patient. And it has been estimated in IVF that 5 to 18% are having the poor response. So this has been seen quite frequently these days. What can be the reason of this? We literally do not know, but one we can think over. Yes, something is there which is really creating so much of problem for the fertility. How to identify the poor responder? Very good tool of transvaginal sonography, what we do, and we see AFCs, and we can see the AFCs before stimulation, which very well correlate with the oocyte retrieval, but not always. You give stimulation and finally you see there are few follicles are only coming up and all are just remaining like that. So this is very much important that individualized protocol has to be done and there should be early initiation of the treatment, but we cannot stop the stimulation. We should counsel properly in detail and then the stimulation should be started. We all know about the poor responder. The good classification has come from the ASHRAE Bologna criteria that the advanced age more than 40, then there are chances of poor response. If the AMH, the ovarian reserve test, like AMH is less than 1.1 nanogram per ml or less than 7 AFCs are visible on day 2 scan and the investigation, then this patient is going to have the poor response. And previous file is very much important. We should all assess and then only we should try to counsel the patient. If the patient had already less than 3 eggs in conventional stimulation, that means this is having a poor response, and out of 2 out of 3 comes in the criteria of Bologna criteria. But what is the problem with criteria? That exactly we do not know that these patients are having the poor response or not. This was the reason the Poseidon criteria came, which is very closely in touch with the clinical practice. The group 1 is less than 35, AFCs are more than 5, AMH is more than 1.2. And similarly, if the age is more than 35 and the criteria of ovarian reserve is same, this is group 2. And in group 3, it will be more than 30, age is less than 35 and AFCs are less than 5 and AMH is less than 1.1, it remains. And similarly, the expected, the group 4 is more than 35, AFCs are less than 5, and AMH is less than 1.2. So group 1 and 2 was if the response is not good, it is totally unexpected. And in group 3 and 4, we know that already the criteria is less because the age is also more, and the AFCs are also less. So it comes like that. It is expected that we are ready for that. We counsel properly to these patients. What happened? My slides.
Ma'am, click on left bottom.
Yeah, there are too many problems.
To the left bottom, you can see.
Slides. Okay.
Yes, ma'am. Just have to go.
It's stuck somewhere.
Ma'am has to go one slide before.
Yeah, but I cannot change this, dear. This electronic, what is the, it's going aage. Okay, okay, thank you. So there are the counseling tool for these patients, the FOI, the follicle to oocyte index. How this works? This finds out the ratio between the total number of oocytes retrieved at OPU to the number of antral follicles. So this addresses the hyporesponsiveness or the resistance to ovarian stimulation. If we see so many follicles and the stimulation, after stimulation, the less number of eggs comes out. And it has been already seen that there is an increased number of pregnancy rate by 25% if instead of 2, we get 3 eggs. So this is a very important finding, for we keep on struggling for each egg, while doing the oocyte retrieval. So it can be the normal FOI, if the more than 50% of the eggs are retrieved, which we saw during stimulation, and low FOI if it is the less than 50% are seen, less than 50% are oocyte are retrieved after the stimulation. So what can be the causes of these low FOI? It can be a low gonadotropin dose, starting dose. We have not predicted that these patients are having more resistance and they require more gonadotropin dose. So we have started with a less dose on the starting point. And there will be the asynchronous follicular growth. There can be a technical issue while triggering or while doing the oocyte pickup or during maturation or in your lab. But we should not forget there is another component is the genetic or environmental problems, pollution, which is going to give this problem. And there is another tool called ART calculator. With this, one can predict number of mature oocyte, how many are the actual number of collected oocyte will be the euploid blast. So one can download ART calculator, and probably if you fill up the female age and the sperm source, whether it is from the ejaculate or epididymis or testicular, and if you just click, it can calculate that how many mature oocytes will be there and how many blast can be formed at the end of the lab. What is the scene behind? Even though the FSH level is normal and there are too many good follicles are seen, either they can be only 2 or they can be plenty. So always after the stimulation only, we can find out that what is the true reserve of that female. Without stimulation, one cannot find out. So this is very much important. The counseling has to be done. Another, the point is the LH therapeutic window. If LH threshold is more than 1.2, chances are there that the patient will have the impaired follicular growth or impaired oocyte maturation, inadequate androgen or estrogen synthesis. And if high level of LH is there, then it can suppress the granulosa cell proliferation, follicular atresia, premature luteinization, and finally the oocyte development will be compromised. So LH also plays the role which we do at the day 2 before doing the stimulation. So what we require, there should be a change of protocol, there should be a change of trigger. Let's come on unexpected POR, the Poseidon 1, 2, and expected POR, Poseidon 3 and 4. In unexpected POR, what happens? What can be the causes? There can be a decreased sensitivity of follicle to FSH receptor. Reason may be probably genetic polymorphism, which affects the gonadotropin and receptors. There can be environmental factor, lots of pollution. Probably this may be the reason. Contaminants are there, and increased intrafollicular level of benzene leading to transduction deficiency of FSH receptor also has been observed. And this can have the PBC in follicular fluid. It has been also seen that these contaminants can create problem, and finally the oocyte will suffer. Therefore, if pre-treatment protocol, if we consider the ART calculator or we do a full genotype screening of the couple, then we can come out that yes, this is the reason, and consider the androgen in selected patient, especially Poseidon 2 with ovarian reserve marker. If there is lower limit, then androgen to be given as a pre-treatment. The stimulation protocol, when we start in Poseidon 1, 50 to 75 is no variant. So one can have the 75 to 150 recombinant FSH to be added. And if we have to consider LH in these patients, then 2:1 ratio is the best ratio, where the recombinant FSH and our LH to be started from day 1. We have to see the previous record. If 3000 IU has been utilized in the previous cycle, then this ratio, 2:1 ratio of FSH and LH will be the best stimulation for Poseidon 1 if the age is less than 35. Poseidon 2, recombinant FSH dose, one should start with little higher, like 300 IU daily, and one can consider DO stimulation in these patients. It has been seen the recombinant LH 150 IU, if it is added from the day of stimulation, either it is an agonist cycle or antagonist cycle, it gives the better result in these patients. Normally, what we do, GnRH antagonist is a very good patient-friendly protocol, where we start from the second day of the period, we start stimulation, and as soon as it becomes the 14 mm, we start the antagonist, and finally we get the good 17-18 millimeter size when you give the trigger, and after 34-35 hours after, one should do the oocyte retrieval. It looks very beautiful if it is a normal responder, but you have to really change when it comes to the poor responder in these patients. So there are the use of recombinant FSH. It has been seen in poor responder. If we do give the recombinant FSH in these patients, these are associated with significantly more oocytes when we retrieve. So this is very much important. Whether you have the GnRH agonist cycle or antagonist cycle, recombinant FSH gives the better result. Oh, sorry. Again. My slides, yes. So this helps in rescue if the ongoing stimulation in women with initial slow response. So one should add 50 IU in initial recombinant dose, and one can see that yes, it will give the better result. If recombinant LH is added in these patients, then it has been seen that excessive suppression of endogenous LH after downregulation with GnRH analog, it will be giving, if there is a presence of polymorphism of LH molecule, it gives the better result by reducing the bioactivity of the molecule or the polymorphism of the LH receptor. One comes to DHEA, dihydroepisterol. Once DHEA came, all patients were using this because DHEA was looked like a big challenge, that this is the only drug which will help. But this has shown that in a poor response patient, this gives the better result because it counterbalances the impaired thick-up function and androgen production observed in the advanced stage. And it gives significantly higher live birth rate in these patients. So 75 milligram per day to be started, and it has been seen minimum of 8 weeks to be given, and then it gives the better result. Now comes to the double stimulation. Double stimulation, recently it has come that DioStim combines conventional follicular phase stimulation with the luteal phase stimulation in the same cycle, which gives the better result, and we can collect more number of oocyte in the same cycle. It has been observed that there are the follicular proliferation 3 times in same menstrual cycle. So one can utilize all the three flaring up proliferation of follicles, and one can collect the same in the same cycle. How to do it? The first day of the menstruation, the gonadotropin has been started. It is at the 150 to 300 IU per day. It is given, and finally the antagonist started. And here the agonist trigger, and with the agonist trigger, once one has done the pickup, and then after 1 or 2 days interval, again the gonadotropin with a little higher dose in the same cycle has been started, and second pickup can be done. So one can collect good number of eggs, and chances are there that the patient can have the better chance of forming the euploid blast and the successful pregnancy. In an expected POR like Poseidon 3 and 4, the pre-treatment has to be given androgen, growth hormone, CoQ10. Long protocol with the E2 or OCP can be given, and the chances are there one should think over about the DioStim. The stimulation, the Poseidon 3, the higher doses of the recombinant FSH is required, and if long-acting FSH is available, then one can try that also. Poseidon 4, one should start with the 300 IU recombinant plus 150 IU of recombinant LH. Trigger has to be given in antagonist cycle with SCG, GnRH agonist. Either of it can be used. But if we are doing the DioStimulation, the GnRH agonist trigger has to be given. If there is a low FOI, then one should have the adjuvant treatment. One should consider the timing of retrieval. One should give the dual trigger, and we should try to collect the good number of oocytes in these patients. It has been seen that the ovarian stimulation with the exogenous gonadotropin at the maximum 300 recombinant FSH should be used rather than the natural cycle. Sometimes we think that there is only 1 or 2, so we can use the natural cycle. No, we should give the higher dose of recombinant FSH and we should do the stimulation in those cases. So the long-acting protocol, if we try in these patients, it gives the better follicular synchronization after down regulation and gives the good pregnancy rate in these patients and increased late luteal phase, promoting the early recruitment. So it establishes, if you use the OC pill, it establishes the estrogenic environment, it decreases the follicular androgen, leading to delay apoptosis, and the progestin component of OCP suppresses the luteinizing hormone and may synchronize the follicular development. So OCP also can be given in these patients. Now androgen comes. Androgen pre-treatment also should be considered in these patients. This is the new paper which has come up, and it shows that the biological evidence has shown the androgen-induced FSH receptors on granulosa cell leads to an increase in the recruit ability and growth of pre-antral and antral follicles through IGF-1. This is the latest trial which is going on and started in 2015. Nicholas is doing, and it will finish in June 23. And it is also showing that daily dose of 5.5 transdermal testosterone pre-treatment for 60 days, if we give in this group, then chances are there that better recruitment of eggs will be there. Another drug is growth hormone. This rationale to use the growth hormone in this group in ART, in fact, through the IGF-1 has synergetic effect with FSH on follicular development. And this adjuvant with gonadotropin in patient with POR has been showing that we can have the increased number of oocyte and there will be less ampules will be used for the recombinant. So growth hormone also may be used in these patients. We did the study in Mansi and we found on 481 patients, we found that 27.4% of the patients were poor responder, and in this pregnancy rate was 23.3%. So you have to tackle these patients very carefully, counsel them, and find out which management, which protocol will be the important protocol for these patients. So I can conclude here, there is no single best protocol which can convert poor responder into high responder. It is preferable to opt simpler and less expensive protocol for the ovarian stimulation, an individualized approach at all steps of the ART treatment, including targeted pre-treatment evaluation, the choice of GnRH agonist, antagonist, trigger, adjuvant therapy. You have to consider all tools such as FOI and ART calculator can help to develop individualized treatment regime and importantly help to counsel patient about their reproductive prognosis. Thank you very much, and I'm sorry that my slides were not moving. Thank you, dear.
Thank you very much, Dr. Sudha, for your lucid presentation. Thank you so much for clearing so many doubts about poor response. And I think the audience would want to ask a couple of questions on this. Rajapriya, do we have anything here?
Definitely, ma'am. Ma'am, I think her presentation was superb. Even though her slides were not moving, she didn't lose her attention. Like her attention was gripping because I think she put it in a nutshell how to handle based on the age, AMH and AFC, and what are all the other nuances we can use. Ma'am, so that, ma'am, how far you use this growth hormone or testosterone or DHEA as part of your pre-treatment?
In my Rajapriya, in my practice, I use more commonly testosterone, and testosterone gel is available. I give 1 month before, and it gives a very good result. Even though you collect only 3 oocytes, And out of 3, if 1 blast comes out, it gives a very pleasant to give the pregnancy. So I'm using quite frequently testosterone.
Which part of the body you suggest them to apply the gel?
It is at the front of abdomen, normally. Normally after it drying up, and that is the wider area. So 2 puffs to be taken if it is endogen gel, and it gives a very good result.
Thank you so much, ma'am. Thank you so much. I think session 1, all my past presidents made it a beautiful.
Thank you so much for calling.
Thank you.
I was little depressed when the slides were not moving, because my slides are made by my daughter.
They were so good.
She will kill me. I don't move. So thank you so much for giving me time for this presentation.
Thank you. Thank you to both our speakers for covering the entire spectrum of COH, from hyper-respond to poor response, and to put it across very, very well to our viewers. I'm sure all the doubts are clear. That is why we don't have any questions over here. Thank you so much. Thank you very much.
Thank you so much. And we are very glad that we're moving on session 2 on time. And for session 2, we have a vibrant Secretary General of Indian Fertility Society, Dr. Surbeen Guman, to be the chairperson. And she would never say a no to any invitation. How many ever programs, she tries to juggle and accommodate everything, whether be it a physical meeting or a webinar. And she's got a fabulous faculty experience. She's the director and senior consultant at Max Panchsheel and Patparganj. And she's the chairperson of Reproductive Endocrinology Committee. She's been in the past the treasurer of the Indian Fertility Society, currently secretary, and she's won many awards to her credit. I would just say that it is the readiness with which she helps us and encourages us to do the various activities. Now they've brought in the surveys and they keep putting pressure, and we have monthly executive committee meetings. So I guess each person is setting a higher standard. If Sudha ma'am had one set of goals, the next team is having more goals. And we are trying all our best to keep pace. And for that, for the panel, I've involved a lot of secretaries and past secretaries, because we know how we are struggling to put all these things together. So very happy to introduce Dr. Surbeen. And Dr. Surbeen, I would request you to introduce me formally as the moderator, and then I would start introducing my panelists.
So Rajapriya, it's always a pleasure to be on board with you. You are so energetic, and I think you just pick up the right issues and discuss them. So you're the Managing Director of Srinivas Priya Hospital, Perambur, Executive Committee member, FPSI OGSSI ATN RCOG. This is the current position. Foxy Endometriosis Committee member, Secretary Perambur IMA Women's Wing, and the Secretary Indian Fertility Society at Tamil Nadu chapter, and doing a lot of good work in this field. We are always, clapping our hands for you on all the things which you are doing.
It's all possible because people readily accept. When I request you to take part, all of you immediately accept, and that's where I stand to be able to do these programs. So without further delay, I want all of you to get back to your evening clinic on time. And for the panel, I have a beautiful set of people. This is, I thought, post-ART law, the way we are thinking and the way we are practicing would have to change. And we had a lot of guidance from our previous 2 speakers, Dr. Kuldeep and Dr. Sudha Prasad. And with respect to this program, Dr. Sonia Malik, we had already introduced. I'm actually sorry, Sahidi, you should be showing me all the slides, right?
I will be sharing
So I'll just stop share, and then we will wait for you to show the slides before I do it. Yeah, we have Dr. Sonu, Dr. Anju, Dr. Malik, and Dr. Sonu Balara is a very close friend and the person who won the Best Chapter Award last year. She's from Haryana at Artemis Hospital, the unit head Department of Reproductive Medicine, with many years of experience, and she's from reputed Army Hospital as a postgraduate. And currently as a secretary, she does a lot of activities. She was recently, both of us had the opportunity to work together in the ICMR standard treatment workflow for the female fertility factor. And it was great doing that program with her. And she's also associated with very many charitable organizations as well. And we also have Dr. Anju Mathur. She's the past secretary of the Rajasthan chapter. Currently, she is the SIG convener of the Environment Infertility in Indian Fertility Society. Again, I have a beautiful from north, south, east, west. She's from Jaipur, Rajasthan. And madam is from Delhi. We just introduced her in the previous session as a chairperson. Can you move further, Sahiti? We have Dr. Divya from Karnataka. She's the secretary of Indian Fertility Society Karnataka chapter, the medical director at Genia Fertility Center, Bangalore. A very vibrant person, and she's contributed to many papers and textbooks, and she's done her fellowship in reproductive medicine. And she holds a very high advantage that she's also passed out from the National Law School, unlike the rest of us. So good for you, Divya. The next person is Dr. Padmaja.
Thank you.
Yeah, she's got very many awards and affiliations. And she's again a very vibrant person, Dr. Rama Memorial Gold Medal Award. And I have known her from Vijayawada as a person who's done many publications and with many special interests. And she's the past president of Vijayawada OBG Society. And I'm hoping that Padmaja would soon get aggressive into Indian Fertility Society as well. And we have Dr. Puneet Arora, the founder member of the Fertility Preservation Society of India. She has done her MRCOG and served very many years in the field of OBG. She's currently the director of the Center for Infertility and Assisted Reproduction, CFAR, at Gurgaon. And she's executive member of IFS as well, with very many interests, particularly recurrent implantation failure and oncofertility. With this beautiful list of panelists, I would like to move over to the program per se. So is my slides back?
Yes, ma'am.
Yeah. So as the law has come in front of us, we are now cornered in every directions. We have to be very cautious that we don't bring about hyperstimulation. And with respect, we had a lot of debate that even if it's a donor, there was a 7 follicles debate, and we were all wondering how we plan our stimulation such that we get the exact number of follicles so that we don't get into any kind of situation with the expected law. And with respect, initially, even if we created too many embryos, we could help the woman get pregnant, give her some economic concession, and use them for embryo donation. Currently, this particular law doesn't allow us to encourage the patient. It's either discard or give for research. And there is now the number of embryos transferred as well. There are clear-cut rules. At no stage we can transfer more than 3 at the best. And generally, even the patient is aware that beyond IVF, that ICSI gives better fertilization. And the whole thing boils down to a numbers game. How many follicles, how many oocytes, how many embryos, and what helps them to get pregnant. And if they are not happy with the way we are giving the discharge summary details, or if the payment is going high or low more than expected, definitely if it is low, they are not going to complain. But if it goes higher, they are definitely going to be worried. And if the pregnancy rate doesn't happen, they are going to feel that they didn't get the value for the money they spend. So we need to have this grievance cell in place, which is more within the control of the hospital. And if we do not address these grievances, then you have the appropriate authority to come in, intervene, and check on you. And recently in Tamil Nadu, we did have a bad experience where one of the chain of hospitals got into trouble. So with respect to the donor eggs, and which came in the national news channel. So we really have to put our act together. So I hope that this particular panel will help us to get all these things in place. So we understand the law and practice according to the law and try to be as safe as possible. And during dose planning, I'm just talking about a random first cycle ICSI. It's a pure male factor, not a female factor. I just want each of the panelists to give their view. How many follicles would you plan? Say she's basically having no problem, a perfect good reserve. How many follicles would you think would be optimum for you to stimulate so that you would get the success rate of a 40 or 50% you hope for? Right? So let me start with Dr. Divya.
Yeah. Assuming that this is absolutely male factor infertility and she's a normal responder, I would aim at somewhere between 10 to 15 follicles, so that at the end of the IVF, I would want anywhere between 6 to 9 embryos in hand, so that I can give a cumulative pregnancy rate. What we have to look at when we are planning for embryo transfer is to look at a cumulative pregnancy rate, which is say 40 to 50%, then probably up to 60 to 70, then probably up to 80 to 85 is a cumulative pregnancy rate what I'm looking at. So I would want at least 6 to 9 embryos in hand. So I would want say probably 10 to 15 follicles post stimulation.
Okay, Dr. Sonu, would you like to add on, or would you have a different strategy in mind?
No, I would also agree to Dr. Divya, at least 10 to 15 follicles so that we have 3 to 4 very good blasts, and so that we have a good success rate.
Right. Do the other panelists have any differing opinion, or you wish to concur? If any differing opinion, please share it. So a lot would depend upon the lab as well, right? So if your lab is able to, what's the blast rate, or if you have a practice of putting a day 3, day 5 embryo, all these would come in place. So how many of you talk about a per cycle success rate, and how many of you would talk upfront as a cumulative pregnancy rate? Can I have the opinion from Anju? Do you speak as a opinion of a cumulative pregnancy rate? Is Anju around? Not yet. Okay, Dr. Puneet, would you just say as the first ICSI, would you talk about a cumulative pregnancy rate to the patient?
So I think it's important. It's obviously it's an era of individualization, right? So I generally talk about their per cycle success rate with the investigations I have. If they haven't had any successful or any IVF before, I would talk about per cycle rate and the take home baby rate, rather than the cumulative pregnancy, success rates.
Right, because right now in Chennai, we are loaded with IVF centers. We are so cautious that we give them the best promise in the first cycle. Of course, I think in the long run, when something goes in the first cycle, slowly we introduce that this is actually a cumulative rate.
Rajapriya, can I make a comment here?
Sure, ma'am.
So if we notice this is male factor and it's going to be an ICSI.
Yeah.
So if there is a discordant growth, then we need to know how many mature follicles which will contain M2 is what we are targeting, because the smaller ones which are less than 12, we would not have M2s in them. So it's very important that we take the size of the follicle into consideration when taking our decision for an ICSI.
So that's
but Dr. Surveen, then how do we start the stimulation? Like how do we aim to get at least 12 to 15 M2 if you're saying what?
So then we should be very careful with these cases. And if we are seeing a discordant growth in one cycle, we should be giving them a suppression of probably progynoa so that discordant growth doesn't occur, or an agonist cycle so that we have, follicles which are optimum. Otherwise, what will happen is we'll have smaller follicles, bigger follicles. We'll take out only 8. Out of 8, we may have just 4 M2s, and we may end up with very few M2s. So now our clinical individualization is going to become very, very important. Which case for what?
Yeah.
And
So
can I add on, taking to Dr. Surveen's conversation, I think I agree that individualization is important. We should not get biased that it is a male factor only, because invariably we see surprises that infertility is a stressful situation. Even if there's no female factor, we could see the change in the egg quality. So we should target for what Dr. Divya said in the beginning, 10 to 15, even if it's a male factor, and not give them mild stimulation or something, assuming that the eggs are completely healthy and it's just a male factor.
So the whole idea of this slide was that point. We just can't take it as a male factor, and somewhere in the mind, we need to understand it is a cumulative pregnancy rate, and we'll have surprises with the female.
Can I add a point?
Yeah.
In male factor, when there's severe male factor, we see that we have even biochemical pregnancy and pregnancy loss. So it's not just a positive beta HCG. So we should always be talking about cumulative pregnancy rate, and as Dr. Puneet said, the take home baby rate, because the couple came to us not to have an embryo in the lab. They came to take a baby home. So right from the beginning, we should be telling, we are going to try to optimize to help you take a baby home. Because with severe male factor, I see a lot of somewhat blighted ovums and things like that. Initially, because the male genome expression, the transition, there is some fault there.
Right, right. Sonia ma'am, how many embryos, ma'am, you would aim to create? Sonia ma'am? I'm not having Sonia ma'am around. So, Dr. Sonu, how many embryos? Like we said, like so many follicles we would like, and so how many embryos would you normally take it as a good program to be able to give this take-home baby?
See, day 3 embryos, at least minimum 6 to 9 if we can get. But I don't know if after this ART law, how many, like nothing is very much clear. So maybe Sonia ma'am or Dr. Surveen can just throw some light on this, like how many embryos and 7. Now the number is not there, but still we have to be vigilant. How many follicles or how many oocytes retrieved should be.
Yeah,
As long as we are doing it for their self thing, I don't think there is a limitation. It is only when we have a third party, when we're doing a donor, that we have to be very cautious, because one of the reasons these laws came is they felt that women who are healthy, I mean, there were some deaths. So they said for a oocyte donor, no one should have to, that sort of situation should not happen. So that was the thing. For self, people are willing to take a little more risk, but we can't take any risk with a person who is in the third party.
No, I was just like, there was some, I was thinking about the third party thing, but somehow so that was.
Even if it is self, I think we need to have now a caution.
Yeah.
Can I come in?
What about
Can I come in?
please, sir. What is your opinion, sir?
A good discussion is going on. That's why I wanted to come in. I just spoke on mild stimulation. The limitation of mild stimulation is that only which I highlighted. See, we had to, there was one paper, and that is off quoted always, that we require minimal 15 to 16 follicle to get a better outcome. But that study has not been substantiated by any other large study. That is the, and we always, for last 15 years, we have been quoting that study only. There is no further study has come to our rescue to answer this question, how much is the optimal? Now, but over the period, we have come to a conclusion that we need not to have 15 to give a better optimal outcome. It could be 10, it could be 9, it could be 8 also. So there has been a consensus. I think there is one paper 2 years back which have said that instead of aiming for, because we want to minimize ovarian hyperstimulation risk. So if you are aiming for 15, you can't actually minimize the concept of OHSS pre-clinic goal away if you are planning. So both are contradictory. One at one end you are saying that you are running a OHSS pre-clinic. At other end you are aiming for 15, 16 follicles. How that is possible? Okay, so you have to justify what we are saying, what we are practicing. Consensus is anywhere between 8 to 10 follicles should be okay to give you an optimal outcome.
From the same cohort of follicles, how many attempts of frozen embryo transfers would you plan from the same cohort, sir?
See, if you that will depend on the personal patient profile. If you are dealing with a patient who is old, and if you are getting 10 follicle, only 1 or 2 will be euploid. If you are dealing with a younger person, out of 10, 8 may be euploid. So that will depend on the personal patient characteristic, what you are dealing with.
So can I also come in? I'm not switching on my video, but I'm here.
Yeah.
So I personally feel, since we have nothing written about self cycles in this new act, we should still stick to what ICMR guidelines told us, And there, if it was a day 3 transfer, in a younger woman, it was said that we can transfer up to three embryos. And in an older woman, more than 35, they had allowed up to 4, which now we generally don't do. It's generally restricted to 3 cleavage stage embryos. And if we are transferring a blastocyst, it is 1. So basically, those were the ICMR guidelines till the end. And I think we can stick to that and aim at producing that many embryos. My own way of doing it is that, I generally like to give 1 fresh cycle to a person and 1 frozen to the couple, because it is a self-funded cycle. They are not going to get any money from anywhere. So our aim should be to be able to get 1 fresh cycle and 1 frozen cycle. So that means at least 6 or 7 embryos at the most, if you are going to do a cleavage stage, and 2 blastocysts if you are going to do a blastocyst stage transfer. So that is what we should be aiming at. I do not know. There may be a difference of opinion.
I guess that's exactly.
Can I say something here?
Yes,
sure.
So, your question was that how many embryos do we create? Now, that really depends also on the age of the patient, because we need one euploid embryo.
Of course.
Older patients may give more eggs, but the euploid embryo will be less. Whereas younger patients in less eggs will give us a euploid embryo. So that's where I say individualization at every stage is going to occur now.
Right.
Absolutely. Yeah, but that Surveen should be the first stage when you are trying to stimulate the patient. You already know the age of the person, and therefore your individualization should be happening at that stage.
Yeah, so
in order to see the number of eggs that you are going to get from there, and finally the number of embryos. Now, Rajpriya was asking us how many embryos do you aim at?
Yeah.
So that is
she's written how many embryos to be created. So that depends actually on how many euploid embryos you'll get from the total embryos. That
no. See, the Surveen, euploid is a question of PGT, which we haven't come to as yet.
No, I agree. I agree.
So the number of embryos created would be the total cohort that you have created. Whether they are euploid or aneuploid, we don't know. And we all know that it is an age-related factor.
For a younger patient, we would require less embryos. For an older patient to get that 1 euploid, we may require more. So we can individualize according to age is what I'm saying.
Yes, ma'am. Because no point in
Dr.
doing
Rajpriya.
Yes, ma'am.
If I have to comment on the 3rd point in this current slide, we are more answerable to stored embryos now.
Absolutely.
I was little skeptical on this point, because as a reproductive medicine specialist, we are always answerable. It is
always.
Always more answerable. So we are always answerable. And just because the act has passed, I don't think that there is any change on this.
Yeah, because I have some of the embryos which are more than 10 years with me, unpaid. But then now we have been given at least some guidance, like you don't have to stick on the embryos more than 10 years.
Yeah, you should discard them before the inspection.
Yes. So
even before the ART Act was passed, in the absence of law, in the absence of an act, the guidelines have to be observed as law. That is according to the law of the land. So now, till now, the ICMR guidelines was there.
The law.
So was a law. We have to foresee, or we should consider that as an act in the absence of law. And in that also, 10 years was the time period where we have to store them, or we have onus on those embryos, or we have to safeguard those embryos.
Correct.
Now, when you're planning a stimulation, I think most of us would agree that we look at the age, as we rightly discussed now, the body mass index, the basal FSH level, and the ovarian reserve based on AMH, AFC, and the previous response. Now, are there any other factors other than these conventional factors you would look at? I would start with Dr. Divya. Would there be anything else you look at besides this when you start on predicting the response? This is going to be a normal responder, a high responder, or a poor responder.
I think most of it is covered here. Apart from the antral follicle count, we also have to look at the antral follicular size. and also the synchronicity between them. As Dr. Surveen said, like, we have to have a good cohort of follicles. But as clinicians, we'll be able to judge that on day 2 itself, because how is the cohort? Do they have a discipline in that, follicular cohort is what we'll be able to assess at that point of time. So apart from that, not just the anti-follicle count, but probably we can add on the anti-follicle size as well. Apart from that, I think everything has been covered.
Dr. Puneet, as Dr. Divya said, sometimes you would find that antral follicle too tiny or a scarred appearance, some white dashes, and there won't be a fine texture. So do you think that these are becoming more important when you are looking at the fertility preservation point, like how many follicles you're going to be able to get in that kind of an individual?
Yeah, so I think I would say I was about to kind of a comment before, if you would have asked this question, I would have about to comment that FSH, not a very, good predictor of the response type, we all know, because that can have a monthly variation also, and there are a lot of other factors it depends on. But yes, if you see a cohort which is unequal or non-coherent, then FSH comes into picture, and then you can, base your, let's say that you want to stimulate her with 225 or 150, 187.5. But if there's a discordant growth, you may want to start a little higher up or a little lower, depending on the FSH value. So otherwise, I would say that if it is a non-coherent growth, you would start with the planned dose based on more age, BMI and all, rather than the incoherency in the antral follicular count.
Sonia ma'am, if I ask you to tell the top 3 of the 6 choices, which are the top 3 you would choose?
Age, number 1. Previous response, if she's had anything, and then AMH and AFC.
Okay. Padma, you want to add
I would also want to say that, now more and more importance is being given to the LH as well as one of the factors. So, that part will also have to be considered, although we don't go ahead and test the LH in every patient, but we somehow need to see it in patients of PCOS, especially if there's been a problem with the response in the previous cycle.
So instead of an FSH, would you do an LH, ma'am?
I would do an LH. I would do an LH.
How does it help, ma'am? How does LH help? How do you base your stimulation depending on
So actually, I am a proponent of down-regulating the LH, although lots of people don't agree with me, and most of the literature also says that in IVF it doesn't matter, because once you are stimulating, then the LH goes down, which is
exactly
true. Which is true, yeah. But what happens is that the endometrium goes for a 6er when the LH is high. And if you're planning to do a mild stimulation, as Dr. Kuldeep had said, and you're doing it in a patient with a high LH, presuming that it has come down, and you're going to transfer the embryo fresh, you're not going to get a pregnancy, because the endometrium is definitely not normal. So that is where I'm coming from for LH. 1. The second thing is when you're deciding the trigger. And if the LH at the beginning of the cycle is very low, and you're going to give a GnRH agonist trigger at the end of it, then it is not going to work, and you're not going to get you're going to get an empty follicles over there. So that is why basal LH is important in such patients. That is why I like to do it.
Ma'am, can I add 2 comments here?
Sure, please.
Ma'am, for example, if it is day 2 high LH, usually we see this PCO, but whatever literature has suggested, I think it is not biologically active. So if it is not biologically active, what is the effect on the endometrium is the one.
Why is it high then? That is, I feel,
because it's biologically not active, ma'am.
See, there are if you go to the basic science studies, you will find why is there so much of importance? Why do we have 2 follicular phases now? Why do we have two waves of follicular genesis? We never thought of it before, didn't we? So probably this LH is high because of the second wave of follicular genesis that this woman had. So that is something that we have to consider.
Elevated LH is what we have understood, ma'am. It's a tonically elevated LH, and it's not having any phases of high LH and low LH.
No, that is what we are presuming. But so because we haven't studied it enough as yet, have we? Have we studied it in these patients where the follicular phase is 3 or follicular waves are coming as 3 or 2? We haven't. So basically what I'm trying to say is I agree with you. When you are going to freeze your embryos, it has no importance at all.
Correct.
Except barring the trigger. You know, if the LH is too down regulated, then you may not get mature eggs, and you may get a empty follicles syndrome over there. But if you are going to transfer, for example, in IUI cases, or in patients where you are going to give a mild stimulation and you're thinking of transferring, then in that case, yes, this is definitely going to, I would suggest, Divya, you do the histopathology in these patients and see what happens. I have done it, that's why I'm saying so.
Okay.
Dr. Rajapriya, one more point. Like as they were talking about the discordant batch is there. So I have noticed that when my basal E2 levels are 60, 70, sometimes on day 2 you get those. Although the follicles look same, all of them are 8 mm, but all of them are not having equal granulosa cell steroidogenesis. So some are on the way up, some are on the way down.
Absolutely
so some
correct.
of them are early, and by the time I come off to day 6 itself, that batch would have gone haywire.
Absolutely.
So basal E2 is, rather than an FSH, I would like
E2.
my basal E2s to be less, somewhere around 30.
30,
that is
40.
my comfort zone.
That's exactly what I want. Like,
But then in PCOS patients, we always get a basal high E2. So we should also kind of understand that in PCOS,
PCOS is a totally different group
Correct.
because they behave, they have their own characteristics. What I'm talking about is the other groups.
Thank you.
So now, based on whatever we just enlisted as factors you would look in, would it make a change in your decision whether you're going to use FSH or a recombinant variety or a HMG? Would it make a decision factor in choosing your gonadotrophin? Or would it not make? You would go on a standard, as I would only go for FSH and not HMG. I think most of us would agree that this would make a deciding factor in choosing what combo you want. What about starting dose? Would it be a standard dose throughout the stimulation duration, or would there be a change at a point? If so, at which point you would make the shift? Can we start with Dr. Sonu? Like, it's a standard stimulation if you have. Would you start at 150, 200 and go at the same? Or would you bring it on an up-down at a point?
No, I usually do a step down protocol. And like we were talking about all the factors depending on the age, the AFC and the AMH and the previous response, I would start with 150 or 225 in a normal responder. I think what you're... Yeah. So usually when we start with the monitoring on day 6 or day 9, then I would like to step down if the follicles, they're matured early. So
at what size you would start relaxing and saying, okay, I'm going to go down on the dose? At what size of the follicle?
See, 15, 16, that way if I'm doing 225, maybe I will step down to 150.
All right. So how many days most of you believe that minimum this many days of stimulation should happen before I plan my trigger? Do you have a set number of days, 6, 8, 10, 12? Or you go more by the size?
8
days.
Like
minimum of,
So is there anyone who has dared to do it less than 8 days? Or sometimes you feel if it's been a very long duration, then probably the oocytes are not going to be good enough. Any experiences like that?
Not more than 13 days for me.
Yeah.
I waited up to 15 days.
Yeah.
But my I'm not if you're doing it at less than 8, then you just have those 4 follicles every which have reached of 18 and the others are at 10. So those cycles, there's no way we can do a fresh transfer in them.
All right, Divya, how many of you are still with the agonist protocol? I think there's been a tremendous shift the last few years towards antagonist protocol. Most of us.
Yeah,
right?
most of us are doing antagonist protocols, but it is not the set protocol. A few of the patients, we still go for long agonist protocols. Probably if it is like, endometriosis, or sometimes, very rarely, if it is Poseidon group 3 kind of poor responders, probably in those patients also, I may prefer to do a long agonist protocol because I get good cohort. And basically we have to individualize. And if we have to go back to the question, how many days of stimulation, most of us are usually comfortable with 8 to 10 days of stimulation. If it is going beyond 10 days, that means it is a very important prognostic factor for the outcome of IVF, because that means the follicular apparatus itself is wrong, or there is some defect in the follicular apparatus. That's why the steroidogenesis is not good, or the follicular phase of that particular cycle is not good. And if it is lesser days of stimulation, we have to understand we just are not looking at the nuclear maturation. We are also looking at the cytoplasmic maturation of a oocyte. So on an average, 8 to 10 days is good enough. And stimulation protocols, nothing very specific, but most of us are doing antagonist protocol because it's more friendly and we can give agonist triggers.
Now, planning the scan. All of us believe that basal scan is inevitable. If so, on which day would you prefer? Day 2, day 3?
Day 2, obviously. Day 2, day 3, yes.
All right. So it's only after that scan is done, the injections are decided. It would be decided on that day, the stimulation, or is it decided when you're signing them up for the program itself? Do you decide on that basal scan? That's a crucial deciding factor for planning the stimulation dose.
Whenever we are planning the stimulation in that particular cycle, we have to see the antral follicle count and the size, because we cannot just go by the basal scan, which was done previous
cycle. Sonia, would you like to add on anything?
No. I do the same thing. No, definitely yes.
Going ahead, we have.
Yeah. Dr. Surveen, I think ma'am's on the. Dr. Puneet, which day do you think you get the trend of that cohort? The cohort is going in the way you want to, or your cohort is letting you down? Which day you think is the key day when you know it's in your hand or it's gone out of hand? Day 7, day 8.
You mean to say that like that?
In your favor, or you would have had a plan. We all have a plan, like I'm going to do this, and it falls by the plan. Sometimes there will be, like as ma'am Sudha ma'am was saying, you don't get the 50% which you're expecting. It's gone out of hand. Which day you think is that important day where the scan plays a role in picking up the trend of the growth of follicles?
So I generally, after the baseline scan, I call them for what I call them like as a recruitment scan, right? 4th or 5th day of the cycle.
So injection or 5th day of cycle?
Of injection.
5 days of injection.
Yes. Either the 4th or 5th day, because I think that's the time when most of the recruitment has happened. And also that's a time for deciding on the start of the antagonist.
Right.
So depending on that, whether we need to increase the dose or we need to start the antag. So 4th or 5th day of this injections, I generally call them for a follow-up scan, the first follow-up scan.
Fine, I guess most of you would agree, or anyone differ in that at least 5 days of stimulation for the next scan, right? Now, this is a scenario where there were 6 AFC and there was just exactly 1 follicle which came up in spite of all the injections which were pumped in, right? So this is typically that less than 50% response. So when there's a single follicle and the woman is, say, around 38 years old, and she would listen to whatever you say, do you want to move forward? And this is a situation where you want to continue or abandon the cycle. Say you've given her 5-6 days of injection and just a single follicle came up.
I think, Rajapriya, it will depend on what her AMH is. If she's a poor responder, we do often see such kind of scenarios that, they may not respond. All follicles may not respond. If she's more than 40, low AMH, this is a common scenario we find. And I think it's all about the counseling with the patient, where she's happy to go ahead with 1 follicle. So I'm sure this would have well been counseled if she's more than 40 and the low AMH.
But it's a very tricky situation. No, we would want at least 3 or 4 follicles to grow, but we are stuck with 1.
That's
right. So how many of you would dare and go for the OPU, or just
Rajapriya, I was stimulating my cousin and she made just 1 follicle. So I told her, okay, let's abandon the cycle. But she was adamant. She said, no, Divi, I want to continue. She made 1 embryo and she just delivered a baby girl 2 days back. So I was more worried than the patient. So counseling plays a very big role. Patient has already spent some amount on the injections. So we just have to counsel them. Maybe we are more worried and the patient may.
Well, these are very tricky situations which we get cornered, and then, as you rightly said, the patient moves us forward most of the time. Like we want to take the back foot, but the patient says, go ahead. I've spent so much. I want to just see what happens.
So Rajpriya, there's another angle to it. The patient, sometimes what you want to tell them is that they want to do, and they are hell-bent on doing cycle after cycle of their own. They don't want to opt for a donor egg. And in such patients, if you get just one follicle, you need to tell them that, look, we want to go ahead with this one follicle, one egg, because we need to understand whether the quality of the egg that you're going to give us is good or not. If your follicle is also one and the quality is also of no use, then I wouldn't suggest you to go for another cycle, because it's not going to lead us anywhere. However, if we get a good oocyte and a good embryo out of this one follicle, you should collect more. Yeah. So that helps us to counsel her to go ahead with more cycles of her own. Otherwise, you can be very, very confidently telling her that she should go in for a donor egg.
So I guess counseling and their finances and their decisions.
Absolutely.
The whole thing is a mystery which is going to unfold in days to come.
Sometimes a 45-year-old will insist that she wants to do it with her own eggs. Or sometimes a 42-year-old is coming to you for fertility preservation and she produces only one. So these are situations which we have to, essentially counsel them and see what they want and go ahead if they want it, because it tells you and it gives you proof to tell them that we were correct when we were telling them that this is not going to help you.
So what ma'am is saying, Rajapriya, I would like to add that if the patient is of a younger age with a low AMH, then maybe with a one follicle we can go ahead.
He's going to conceive. Yeah, absolutely. Absolutely.
So I just want to say one thing here, Rajapriya, that one follicle, the data which shows when you're counseling a patient and there's one follicle, IUI and IVF have actually the same rate if it is unexplained infertility.
17% is the success rate in an IVF converted to an IUI in a single follicle.
Yeah.
17%.
Okay. Yeah. But if there are two follicles, IVF has a higher success
rate.
Okay, thank you. So here we have a typical PCOS patients with enough and more antral follicles, but in previous stimulations, she has hardly had one or two follicles growing. So would you choose a step up or a step down protocol if you're planning an ICSI with this kind of a patient? Dr. Anju? Dr. Anju, you're around?
Yeah, I'm around.
Yeah. So, hi. So
hi.
Would your preference be a step up or a step down protocol in a PCOS patient?
In a PCOS, my distance would be, step up.
Step up.
The lower dose and then go on to a higher dose if required.
Okay, that's being very cautious. And Dr. Padmaja, now this is not a person who usually responds. So would you be tempted to go on a step down protocol?
I would.
Yeah.
Because as I was telling you, I like stimulations of if you're going in a step-up protocol, by the time they are fighting out, deciding itself, it is going to take 10 to 15 days.
Yeah.
By then the patient and every day we are going to have another set of relatives coming and asking me what they're doing. So I usually...
It's a tricky balance. So if you know the previous response as a very resistant PCO, there is a tendency to go. So what would be your starting dose?
I usually, because previously she had a poor response, I would start off if I'm using HMG at 225. And after 4 days, as we're telling, or day 5 of injections, do a scan. Look from those 8 mm, how many have come to that 12-ish mm. And based on that, and looking at the endometrial pattern, which gives us a very good indication of the estrogenic level and the steroidogenesis biological activity, then change it.
I really like that point. Sometimes it's actually the endometrium we should look at a lot. It
Absolutely.
you what kind of a oocyte is sitting inside and the endocrine activity. Sonia ma'am, what is your call on this kind of a PCOS? Would you go a lot by the BMI as well, whether she's a lean PCO or an obese PCO? Or LH, no? Would you look at it for your starting dose? And then what about the HMG?
Well, see, this type of I have been, in our own center, we've been giving theses on PCOS for various types of analysis. So one of the theses was on the type of PCO and the outcome. and the endocrinal. So basically, if you have a patient who has a high LH in the beginning and a high AMH, and she generally ends up with a poor response like this one. Even if they have a very good AFC, their ovary has a lot of stroma, and as on Doppler, you have very little blood flow. All those features are there. And LH is high and AMH is also high. So these are the ones who are the resistant PCO. I generally downregulate them because they will not respond if you start. You will end up the way the others are saying, with a poor response. So in these patients, you do need to downregulate them. And this is what our study also showed, that if you downregulate them, then you do a stop protocol. Don't go and do an agonist protocol. Downregulate them, stop, and then go in and do an antagonist protocol. But you then need a lower dose. You don't have to start with a very high dose. Then they respond very well once the LH is downregulated before starting the stimulation, because it is the LH which is not letting it grow, no? So therefore, if you do that, so that is what we've been doing, and then you start with 225 or even 187 and you get a very good response. So that is what my take is on this kind of a patient that you've said. And as she said just now, the E2 is definitely very important, and the endometrium is very, very important, because these are the patients who have a lot of androgens in them, and therefore the endometrium is going to be less responsive because of the high androgenic milieu over there. So looking at the endometrium is definitely going to tell you whether they are responding to the estradiol or not, whether they are responding or not, and the granulosa cells have become active or not. So that part is definitely very, very important.
And also looking at the cervical mucus, madam. As
Absolutely,
we are putting it, we can see the beautiful cervical mucus, and that is very thrilling.
Yeah.
Yes. Dr. Divya, you have a patient who really needs a donor. Okay, now you come into the ART.
Yeah.
Law is there, and then you're calling up the donor bank, right? The donor bank is giving you two options. Patient A is the profile, a para 1 live 1. Patient profile, the other patient's profile is para 2 live 2. Who would you want to choose as your donor? One has a very good AFC, the AMH is high. She mostly has induced cycles. She has registered and she's part of the bank's offer to you. So you'd like
the age, Rajapriya, what's the age of each donor?
The first one is around 27 years old and the second one is around 26 years old. This is what is going to happen to us. We don't even know who the profile of donor is and how they are going to respond when they come.
The problem is that the one who is having a good profile, AFC 12 and AMH 2.8, is actually having 2 children.
Yeah.
So that is going to be the catch over there. We cannot take her because she's got 2 children. And here, on the other hand, you have a PCO whom you cannot take because she is the one who is going to go into high response, and you may land up in a problem. So both of them are unfit as far as the donor profile goes.
You're going to say, I don't want both of them as of
now. None. Get another one. Get a third one.
Okay, Divya, you're going to say no as well? Who's going to dare and choose one? The patient is saying,
some network issues.
Oh, I'm sorry. Supposing the patient says, I don't have time, I've already taken a vacation break for this, and you need to choose someone and go ahead.
I prefer I
would safely choose number two.
Okay. So all of you would prefer the person who has a lower, more controlled AMH and probably a better response.
Yes.
Fine. So that was something. Now, this is a 27-year-old lady, married 4 years with regular cycles. Her LMP is 26th of March. She was started on, this is not an ICSI cycle. She was started on an IUI cycle with Clome and FSH 75 back-to-back 3 doses. So very good AFC count of 20. Now, on day 4, that's the basal scan. It was a Sunday. She didn't come on day 3. So she came on the Monday, where already the right ovary showed a 1.7 centimeter size. There was a small confusion. Could it be a cyst or a follicle, right? So how many of you have been cornered on this basal scan situation where you are wondering whether this is a cyst or follicle? And in that kind of a situation, would you do a estradiol or wait and watch and see how the follicles are growing, or is it a cyst? How would you make that call? Dr. Puneet, how would you make your call? 1.7 centimeters right ovary on day 4.
So
So
1.7.
fourth IUI plan, fourth IUI plan.
And this is day 4 of the cycle.
Yeah.
Okay. So I think I would like to do an E2 progesterone on her, kind of to decide on, because if it is kind of a remnant from the last month, or progesterone would be on a higher side. If it's a new follicle coming up, E2 may go up. If sometimes, you have a cohort which gives one follicle rising early in the early follicular phase. So maybe E2 progesterone would be the best way. I would go ahead to decide on whether we should do stimulation in this cycle or not.
No, by day 9, it went up to actually 3 centimeters, and subsequently it ruptured spontaneously. I had actually planned the 4th IUI for this patient, but considering that this is going to be probably her last IUI before we start talking about IVF and ICSI, I decided I'm going to optimize the situation, and optimizing IUI is to get a better number of follicles and a better controlled situation. So it was cancelled, and she was asked to try naturally. Now here, would you think that probably what has actually happened was a growing follicle and rupture? The wave theory is sometimes a surprise. So if any of you, how often would you consider a wave theory in a non-ICSI situation? Most of the time we believe in the wave theory only with respect to fertility preservation as a random start and things like that. Is it coming as part of our regular practice that anytime a patient walks in, we think about the wave theory?
See, wave theory, as you told Dr. Rajapriya, one is in fertility preservation, as you rightly said. The other thing is also we could consider this if it is a, if it is a dual stimulation, wherein you go through a stimulation, do the egg pickup, and in the second wave, we again go through a stimulation, do the pickup. Probably this could be like a dual stimulation. In this situations also, we do come across this wave theory.
Is Kuldeep sir around? Sonia ma'am, what is your comment, expert comment?
We do get it. We do see this. See, it's not just dual stim here. See, in the case of dual stim, you are actually creating the second wave. You're actually stimulating the ovary to produce more follicles and hence bring in the second wave, based on what we have found in the natural cycles or what the studies have shown. And of course, we know that there is a third wave as well. So basically the cohort is growing at different sizes, and that is why the concept of asynchronous growth has also come in, and that is why we give that estrogen in the luteal phase in order to suppress the LH and thereby not cause any asynchronous growth and the FSH as well. However, that is one. Now you do find it when you're doing FET cycles and it's a non-down-regulated cycle, you do find something growing over there, and it may not, just as you've seen in this IUI cycle, you may find it on day 6 or 7 that suddenly this follicle-like thing pops up, and then when you follow it, it grows. So that kind of a thing can happen even in these FET cycles. That is why the concept of wave has to be there. Otherwise, we would not have been able to do what we are doing now as a random start and do a stim as we are doing. So yes, this kind of a thing does happen.
So Rajapriya, just one comment about your previous vision. In these people, they will have, because the folliculogenesis, the follicular phase was not so great, you will have a luteal phase insufficiency, and then you will have the third wave growing.
Yes.
So in these people, it is better to give a very good luteal phase support so that progesterone will at least suppress the third wave from happening and interfering with your next wave. So then you can give 5 days break and start your stimulation without the break happening.
Now this is another patient, 28-year-old, married 4 years. She had a recent chocolate cyst operated. The left ovary was stuck, but the AFC count was good, 6 and 8 in each ovary. And in the basal scan, a 1.4 centimeter clear cyst was noticed in the basal scan. Now, when you have an endometriosis patient, would your strategy of stimulation keep that in mind? That this clear cyst is probably a resolving cyst, and this is a bit of a scarred, stuck ovary. So, do doses matter there? Planning the dose.
Can you go to the last slide again, Rajpriya, please?
Yeah. She's a young woman.
chocolates is tolerated 6 years.
The
Okay,
left side, the leftover chocolates.
okay. 1.4%.
Yeah.
Okay.
So, Sonia ma'am, would you just like to sum up, like in this kind of a patient, I'm not talking about the exact dose, would you give more of a dose if it's an endometriosis patient? Would antagonist be your choice, or would you go in for an agonist, long agonist protocol? And would you plan a fresh transfer, or sometime would you rather wait for situation to get better and do a segmentation and do a planned transfer later?
So, again, I'm also fond of E2. I'm also very fond of estradiol, especially in cases of endometriosis. And I generally like to start at very low estradiol levels, not even 30, less than that, 20 or 10 maybe. Because basically that is the menopausal level for endometriosis. When we are trying to suppress endometriosis, we like to achieve that dose, that estradiol level. So I like to do that, because what will happen is, even when you're suppressing it with the antagonist, sometimes what happens, or with the agonist, long agonist, you find that the cyclically the estradiol goes up. It escapes that Zoladex or Leuprolide that you have given. And when you do the estradiol in them, even before starting the stimulation, you find an estradiol level of 80 or 90 or 120, even though you've given a depot preparation. So therefore, I generally, whenever I have to plan a cycle in cases of endometriosis, I start with very low levels of estradiol. And then, of course, the dose of the injection is not very different. We generally like to give the same 225 or 300 dose. But if the patient is of an older age group, say 38, 39, then yes, more than that, 300, 375 even. And of course, the trigger choice is HCG. And we generally don't like to give a decapeptide. But if the patient is more than 35 years of age, I like to give a dual trigger. Because basically the quality of the eggs in these patients is compromised, and hence we would want to give that. And timing of trigger, of course, is depending on the size of the follicle that you have.
So thank you so much, ma'am. I think that was a good amount of input which we wanted in that particular scenario. Now, here there are two patients. One is a 40-year-old married 6 months, and the other is 25-year-old married 1 year. Both of them have the same number of AFC, around 3 to 4. And this is the first clinic visit they have. So I'd just like to ask the experts, Dr. Kuldeep and Dr. Surveen, as to what they would like as their input. This is the first consultation. So would you ever talk about a donor oocyte in that kind of a situation? The AMH has not been done. This is just the first visit. You did a basal scan for both this group of people.
I think I would do an AMH.
Yes.
But I would not immediately talk of a donor, because everybody wants to conceive with their own egg. So I would give the option to the 40-year-old that yes, you might require more than one retrieval, and we might have very few eggs, maybe 1 or 2. It's up to you if you want to go ahead with your own egg. For the 25-year-old one, I'll say please take your chances, because the eggs are going to be good quality. I've had young patients who've had only 2 follicles and they've conceived twins. So I would definitely not tell the 25-year-old that yes, she needs a third party. With the 40-year-old one, I would tell her that we can try a cycle with her eggs. Success rate is going to be low. We might need 2 cycles, and we might end up with a third party. So that's how I go about with my patients, because each woman wants her own genetic child. And just to be told on her first visit that, look, you need a third party, is just not fair.
Right. At what point, ma'am, you think like it's time to talk about the third party? At what point, say?
So I do talk about the third party on the first visit. It's only after I talk about the options of her own egg. And then I tell her that, look, if your own egg doesn't work, we have to go to third party. Now, if her first cycle is bad and she yields us nothing or very poor embryos, I would talk about a third party at that stage and tell her that, look, this is not working. You're 40 years old and you would need a donor egg. And I also explain to them that, at 40, maybe 8 out of 10 eggs are not good. They may have some problem. Whereas at 25, if there are 10 eggs, 8 are fine and 2 are bad. So this example is something which I always give them age related. And if she is 40 and first cycle is bad, that is either there are no oocytes or there are oocytes and they're poor embryos, or there's been only one embryo, grade 1, and yet she hasn't conceived. With the 25-year-old, it really depends on what type of embryos. If she's got even 2 grade 1 good embryos and has not conceived, I would still encourage her that, look, they were grade 1 embryos and you need to probably just try again. If you are not in a mood to try again, you're tired and you don't mind that, yes, I want to go ahead with the donor, then the donor is available.
I think recently between 20 to 20 years, there's a rise in the low AMH and low AFC counts. That's something which we are observing recently, quite a lot in Chennai. We are pretty baffled. Anyone has tried PRP injections of ovary to improve the ovarian reserve? Any one of you have experience with that?
No. Dr. Rajapriya, if coming back to your question, if you have to say at some point of time, no, you have to go for third party reproduction. If you are, desperately looking for an answer for that, then if we can increase this age to 45, if a woman is 45 and above, we can always say that third party is a better option, because the probability of getting a euploid embryo after the age of 45 is 0. This is according to the literature and statistics, wherein we can directly tell them, yes, above the first option could always be a third party.
Absolutely.
And regarding PRP, and regarding PRP, yes, I don't have personal experience on PRP, but what we have to understand is what is not there cannot be created. So whether you instill stem cells or PRP use, so what is not there cannot be created. So if at all we are injecting PRP, it can only, theoretically how it works is only, it is going to cause some kind of inflammation inside, so that probably the recruitment is going to be more. So that's how the cohort may improve in that particular cycle. But if we speak about stem cell, the stem cell actually getting converted into an oocyte probably would be, it's very difficult. It's not like this. So all these processes are under research setting, and how far it is going to be clinically useful is yet to be answered.
It's unreal. It may not be directly related to this case, this PRP, but I would just want to add a word of caution over here, which we are kind of forgetting, people who are doing PRP right, left, and center. We have a lot of inflammation in our country. We have a lot of tuberculosis, as you all know, in our country. And that may actually flare up by giving all these things, because we are adding growth factors. And if we are doing stem cell also, that is also, because it is contraindicated to give any of these things whenever, you are trying to stimulate or, or give that kind of a shove to the ovary. So please be careful whenever you are trying to give PRP, because these patients of poor ovarian reserve or poor ovarian response may actually be latent tuberculosis, and you're stimulating them. So just, this is maybe because I'm too supposedly fond of tuberculosis, but then inflammation as such, and now chronic endometritis has become a very big thing worldwide. So therefore, please be careful when you're giving PRP, because you may be just causing an acute endometritis over there, or an acute oophorytis by adding these growth factors over there.
Absolutely.
And also, ma'am, we also have to think about carcinogenesis, especially stem cells rampantly into the ovary. What is that it is going to get differentiated into is what we have to understand. So what is not proven should not be practiced as a routine in clinical practice.
I think Divya, very good point on carcinogenesis.
Very important. Very, very important.
About 10 years later,
yes.
This is a 33-year-old lady, the high AMH, resistant pattern of PCO, but with the REC and HMG combination for given over 11 days, she had almost 27 eggs retrieved from, the AFC was around 40, and around 20 compacting embryos were formed. She went through an FET attempt, but in the first attempt, 2 embryos were kept. She did get pregnant, however, it was a miscarriage. The second attempt, She did not have the economics to deal with this kind of a program. So she had signed up a year ago for freezing of embryos. So that it was like a donation of embryos. And the second was done a complete free attempt. However, it failed. Now the third has been recently done and results are awaiting. Now at this point, this third FET which she had was again a free program. Now, are we getting cornered? Now, she had initially signed up for embryo donation, but in the current scenario, this is no longer going to be an option in ART law. And here I have got cornered that a PCOS, which was a resistant responder, has suddenly bloomed with so many good quality oocytes, I must say, and a good outcome. So in future, right, say the same situation happens to me this year. So is it safer for me to just sign up and discard the embryos when I'm deciding to freeze them, that you just need 6 or 8 good embryos and plan programs? So what would be your opinion be? If I would like to hear from Dr. Kuldeep, Dr. Sonia and Dr. Surbeen. If I get caught in a similar situation, what should I be doing? With respect to economics, the cost.
Before we go into this question, I want a point to be very clear here. What does embryo donation mean?
Her excess embryos, she is agreeing to donate, thereby getting a concession in her program that she won't pay for freezing, and she gets a concession.
No, but this was never there in the law, as I know.
It was being practiced.
Please correct me if I'm wrong, but
this
there
is
is
something
nothing called embryo.
I don't know how to phrase
donation.
that term. See, like how egg
Even if
sharing
it
was
was
there.
previous ART guideline. Even
Rajpriya, but the ICMR.
Egg sharing was an option, but embryo donation, I'm really not sure whether they could actually donate the embryos.
ICMR,
In the consent form, we always had, no ma'am, can be donated, discarded, or given for research. Not in the previous
I
one.
would agree with Divya. After 2017
This was before 2010. This was before 2010.
ICMR has very clearly said not.
This was before 2010.
So I take that point from all of you today that embryo donation is probably, this was done a year ago. So I would take it as it is not agreed. Sorry for that. Now I'm bringing in a situation. So how many embryos do you think at this point, if somebody has an economics problem, how many should we hold and how many should we discard then and there?
This should not be done at all. It has to be discarded.
Yes.
She has to be told that she can take the embryos and use them herself. Yes. But she cannot donate them to anybody because that is not allowed.
Absolutely.
And donate, Yani, this is not donation. This is actually selling, because you are actually
absolutely. It's cost
the
economic.
Yes. The cost is being shared. The cost is being shared, for the in lieu of her embryos, which is not at all permitted.
Right.
So therefore, you have to just tell her that, look, either you pay for your FET or I'm going to discard. Please sign on this.
So that's how we should go about in this kind of situation. If she's
definitely.
Thank you so much. Now we come to the last case. Now this is again a woman who belongs to the lower socio-economic status, 24-year-old, secondary infertility, married in 2017. She's had 2 spontaneous pregnancies in the very first 2 years of her marriage. Both landed up in a miscarriage. She's a hypothyroid, a BMI of around 34. There's a constant drop in the AMH. In 2021, it's around 1.1. But in 2022 February, the AMH has dropped further to 0.26. The male factor is not also a great factor. He has undergone TB treatment at a point. He was into tobacco chewing and he quit it over a point. And if you see, his 7 parameters are all compromised. 13 million, 10% grade A and 1% normal. Now, this is a person who is very particular about using only her self gametes. The first ICSI was done in March 22. The outcome was not great. She had an AFC of 4. And at the end of 12 days of stimulation, 3 eggs were retrieved. 2 were M2 injected. However, there was a fertilization failure. She's very particular. So it's currently July 2022. She's now got an AFC count of around 5. It's an old scar scene. You know that cohort doesn't look great. And around day 9, 3 of her follicles are in 1 centimeter size. So this is day 9 of stimulation. So what would be your options of stimulation at this point? It's a situation where you have to decide how to progress further.
So how is our endometrium at this point of time, doctor?
Endometrium is good. It's a nice triple line around 7.8 millimeter. Day 9, 1 centimeter 3.
That means E2 output is good. So which means the granulosa cells are functioning. If the granulosa cells are functioning and if they're keen to go ahead with the stimulation, I think we could continue. But the scenario will totally change. The endometrium is poor and the E2 output is very less. That means this follicular apparatus itself is not good, and probably we may have to take a call on cancellation of cycle.
Yes, so because already we knew that there was a FERT failure last time, and usually she is growing her follicles slow. She needs a minimum of 12 days as per the previous cycle. So how many of you would say like play caution, don't move ahead, or how many of you would say she's so particular and she's ready to face all the consequences, although she's of the lower socioeconomic status? Pull on. Would you consider increasing more of HMG or increasing more of FSH on day 9? HMG.
At this point of time, it is HMG.
HMG. Okay. So
because the recruitment is already done, so it is more of LH push she needs to grow the follicles further.
So most of you would agree that 1 to 1.4 centimeters is the tricky situation, and if you kind of reach that point, it self-sustains and moves forward. All right. So with this, I would say thank you so much for your time. I really enjoyed all the interaction, all the comments and all the rights and wrongs which we have been doing, and how we have to work on how the practice we've been doing, and trying to satisfy always the patient's requirements. Now we also have to satisfy the legal requirements and take a back foot on what we were doing until now, or take a forward foot on doing the right thing forward. So Surveen ma'am, my chairperson, any closing comments for this session?
Yes, I think it was an excellent panel. You had selected the cases very well. Your questions were different from the normal questions, which we would, kind of see in a panel like this. And I think all the panelists were very good with their review. So just to conclude, I would say with the ART bill coming in, we need to really review our practices. We need to be very good clinical reproductive endocrinologists. We have to have our endocrinology base absolutely clear on what we have to do, how we can correlate our ultrasound with our endocrinology, how we can, as per the bill, go along. That is what I would say.
So I think we should get into
people who don't have that base should stop practicing. Now is the time that they should stop practicing.
Thank you so much, ma'am. Thanks to each and every one of my panelists and my expert panelists, my senior panelists, Dr. Sonia and Dr. Kuldeep, who stood around for a long time. And I am so glad that entire India came together in my panel. And we had Dr. Divya, Dr. from Andhra, we had Dr. Padmaja. I think I couldn't expect a better panel crowd than I had today. And I think together we were able to see what India is putting across in various formats, and how we are all struggling to do the best for our patients, somehow get her pregnant with whatever economical situation she is in. And at the same time, we have to understand we have to protect ourselves first. Now, that's a key point which I wanted to put across in this panel. Do safe practice and follow the law, and keep understanding where to put your full stop. Right. So thank you so much. It was a great evening. I would just request all of you to stick around for one photograph of all of us. So I would keep it as a memory. Sahidi, can you take a screenshot of all of us together?
Yes, ma'am.
Yeah.
So, and thank you, Rajapriya, for having us all together.
Yeah, it's always
I really enjoyed it, Rajapriya.
Thank you, Rajapriya.
Yeah, thank you so much. So with that sweet smile, I wish you a great practice this evening. And those of you who have decided to enjoy the evening in a different way, have a great time. So thank you so much. And thanks to the delegates who had logged in and stayed through this discussion this evening on stimulation post-ART.